I am pleased to present to you the situation of non-communicable diseases in the country, and at the same time the research that we have been conducting in relation to obesity and non-communicable diseases. So we would look at the burden of non-communicable diseases, NCDs standing for non-communicable diseases, and the case of Lebanon, which has been, the studies have been done in collaboration with the Faculty of Health Sciences, Dr. Hwalla and a group that we call the FANS group. The study has looked at the prevalence of NCDs, the prevalence and trends of metabolic syndrome abnormalities, the prevalence and trends of obesity, determinants of NCDs, prevalence of reported behavioral risk factors that can contribute to NCDs, and with conclusions and recommendations. What do we know about NCDs? Non-communicable diseases are now considered a global burden. They account for 60% of mortality worldwide. They are expected to increase to 70% by the year 2020. This is globally. What are the leading cause of death? If you look at the two dates, 2002 and 2030, you still will see that ischemic heart disease and cerebrovascular diseases remain at the top two. And you can see that diabetes is appearing as one of the killer diseases in the year 2030. In EMRO countries, EMRO stands for the Eastern Mediterranean region, where Lebanon is one of the countries of this region. Currently, NCDs constitute 50% of the burden of disease in males and 50% of females. In the year 2008-2009, we started a study, and it's called Non-Communicable Disease and Behavior Risk Factor Survey. This study has looked at the prevalence and determinants, what contributes to the prevalence of non-communicable diseases and obesity in Lebanon. Some of the background, in Lebanon, NCD constitutes an important public health problem. A cross-sectional survey has shown in 1983-1993 that 85% of total mortality among those, and I emphasize the age, among those above 50 years of age have been attributed to NCDs. Looking at the total population in the housing survey in 1996, the cardiovascular diseases accounted for 31% of total mortality, and this is not 50, above age 50, this is the adult population. In our survey, which has been started in 1997, and we have done another one after 10 years, and this is what I will be showing you today, is that we showed that 53% of adult population above 18 years of age and 17% of the population above 18 years of age are obese. So we have 53% overweight and 17% obese. This is in the year 1997, and I will show you data from the recent study, which is not published yet. This one is published. The study took a sample of adults above 18 years of age, 2,600 people. It is a representative sample of the Lebanese population, vis-a-vis age, gender, and location, geographical location. And it was approximately equal numbers of men and women. This study had a questionnaire and measurements. The questionnaire looked at socio-demographic, age, gender, education, work, crowding index. It looked at NCD prevalence, cardiovascular disease, hypertension, diabetes, dyslipidemia. It looked at physical activity pattern. It took nutritional habits using a food frequency questionnaire and 24-hour recall, and also it took information about tobacco and alcohol use. The anthropometric measurements that were done included weight, height, skin fold thickness, and waist circumference. So this is the new study that we have conducted. We also took a subsample And we chose about 1,000 people. It is very hard to make people give you blood. So eventually we ended up with 307 who agreed to do the blood analysis. So from this sample, we had only 307 out of 3,000 approximately, where we did triglycerides, LDL cholesterol, HDL cholesterol, total cholesterol, and blood glucose, which are components and risk factors for cardiovascular diseases. The study results have by gender. The blue is the male and the red is the female. You can see that for both there is similar levels, which shows high cholesterol levels in about 15% and diabetes in about 7%, 15% hypertension, and cardiovascular disease in the range of 7%. So we had, for the first time, figures about the magnitude of occurrence of cardiovascular diseases in the country. If you look by age group, you can see that this bar is not showing very well, but you can see that in the age group above 50 and above 65, the prevalence of cardiovascular disease increases tremendously. So 1 out of 3 people would have, above 65 will have a cardiovascular disease, and above 50 you have 16.4%. And in the female, you can see the figures are similar for men and women. It is not true that men get more sick, but they get more attention. The biochemical analysis that were done on the 307 subjects has shown that also regarding abnormalities, in males the most common abnormality is high blood pressure. This is the percent of men from this group that had high blood pressure, hypertriglyceridemia, high fasting glucose, and low HDL. You can see that these are really quite impressive figures. About 60% had high blood pressure and high fasting blood glucose. Hypertriglyceridemia was 42. Now, in women, the numbers are less, but I will not stand by those figures because it could be that those interested in knowing their blood levels have agreed to be in this study. Metabolic syndrome abnormalities, and metabolic syndrome, you know, is a predisposing factor for diabetes. You can see that we have about half of the population of men and women have one metabolic syndrome abnormality. And this is, we're talking about the whole, the population that has done the study. And those that have more than 3 metabolic abnormalities for the metabolic syndrome were about 34 in males and 25 in females. So more metabolic syndrome abnormalities in males. Now, what about the behavioral risk factors? Because we would like to know if there is a basis for these studies. It is, first of all, to know how many, where are they located, and then what is contributing to this disease, so that if you want to do an intervention in the community, you know where to intervene. So about 1/3 of the population were cigarette smoking. This is the whole group, the 3,000. About half the subjects have low physical activity levels. So you can think that half of the population has very limited physical activity. About 1/4 of the population that we studied have low intake of fruits and vegetables. What about the prevalence of overweight and obesity in the country? You can see that the underweight population is small. Overweight population is about 40% in men and 30% in women. Obesity in Lebanon, I showed you the figure of 1997, and they were 17 so you can see the increase over 10 years. From 17% to 24 and 25 in men. And if you take the whole figure, overweight and obesity, you can see that about 67% of our population are either overweight or obese in men, and about 55% are in women are overweight and obese. This is quite a high number that really makes it an epidemic also for Lebanon. Just for your information, if we would like to compare these figures with the countries in the region, you will see a good picture for the region, for us, if we compare with the region. I mean, look at the Gulf countries. Look at Saudi Arabia, Kuwait, Jordan, and these are obesity figures, not overweight figures. So in Lebanon it's 25, it goes up to 40% in most of the countries of the region. Syria, Kuwait, Jordan, and Iran is lower than us, and Algeria is lower. Now if you compare with the US that makes a lot of fuss about obesity, you can see we're not far from this figure. France, they keep well. Now trends, this slide is really to show you what is happening. These are the figures in 1997, this is Lebanese figures, and these are the figures for 2009. And you can see that the figures are increasing, and the increase is 70% among males and 30% among females. Why am I putting the US? It's not because I like the US, but it is because I am showing you that for the same number of years, for a similar number of years, you can see that the increase was not that high. So we have an increase of 70%, whereas their increase was from 27 to 32, and here from 33 to 35. So we had a much major increase, which means the trajectory that we are following is a much faster increase in obesity. So what are the determinants? Where do we go to address this problem? We have analyzed, examined the association of age, gender or sex, marital status, socio-economic status, lifestyle habits like drinking and smoking, with multiple CVD risk factors, obesity, diabetes, hypertension, and smoking. So we wanted to see if there is a link between those behavior risk factors and the diseases that we have identified. Just to give you an idea about the characteristics of the population that we have studied, we had about 28% of the women were single, whereas 42% of the men were single. And I will show you later why I am distinguishing these university level. We had about similar levels between men and women. So about 30% of the population have university level. But look at the illiteracy, very low. The illiteracy in Lebanon, the illiterate were about more in women, double in women than men, about 5% in men. Now, this slide is a little bit complicated, but this is to show you the relationship, the risk of having an older age, the risk of having education, whether this is linked to obesity and cardiovascular disease. Now, for the risk factors, I can show you here that to have one risk factor, you can see that as the person increases with age, the likelihood of having one risk factor is 4.5 times. It increases 4.5 times. This is quite an increase. And this goes from 3 to 18.2. The risk increases, and for having 3 to 4 risk factors, as age increases, the risk also increases. So there is a tremendous effect of age on having 1, 2, or 3, and 4 risk factors of disease. Now sex, males and females, now you can see that the risk of having 1, 2, or 3 risk factors is higher in males than females. So being a male, you are at a higher risk of getting the cardiovascular diseases. The marital status, it is better to be single. The risk will decrease. So you can see that being single decreases the risk of having cardiovascular diseases. So it is less, the multiple risk factors were less prevalent in single subjects, and the multiple CVD risk factors were more prevalent in older adults and older males. Now, other socioeconomic variables, if you look at education level, you can see that the risk decreases with education levels. So welcome to the education being a good component for decreasing risk of cardiovascular risk factors. And you can see it goes down to 0.3, which means that less risk. The house ownership, you also have to be rich. If you have a house ownership, it means you are better off, and you can see that the risk decreases with financials. So the multiple risk factors were less prevalent in subjects with university education and with subjects that own their houses. Now, nutritional habits, with intake of fruits and vegetables, also there is a decrease of risk with higher intake of fruits and vegetables. So there is evidence that higher intakes of fruits and vegetables will decrease the risk. Physical activity also decreases the risk of having cardiovascular risk factors. So we can also summarize here that subjects with high intake of fruits and vegetables have lower risk of cardiovascular disease, and subjects with moderate physical activity and high physical activity have also lower risk of multiple cardiovascular disease risk factors. What does our diet look like? I mean, we spoke about this behavior. What do you think is the composition of our diet? If you look at our diet and analyze it from the study that we have done, you can notice that there is a fat intake of 37%. We have done a study on our foods, the food tables and the cooking books. All the dishes, even tabbouleh, all the dishes that we eat, we analyzed their fat content, and they were around 39 to 40%. So if all the foods you are eating are about 39 to 40%, it means what we are eating is also 40%. This is a high level. The best is to bring it down to 30%. Now, I looked at the foods. What kind of foods do we eat? Where do we get our energy from? You can see the contribution of bread to our diet, meat and eggs, but I want to alert you to the contribution of fast foods to this diet, which is 15% of energy in the diet comes from fast foods, and 10% from added fats, so you can add them together, and then you have only 7% from fruits and vegetables and 7% from sweets. So this is the picture, just to have an idea what do we eat and how is it related to cardiovascular diseases. We have also looked at the data, and I will leave this to Dr. Farah Najar because she's going to elaborate on this subject. We looked at the data and we analyzed a pattern, a certain group of foods that we eat together, and whether they are associated with cardiovascular diseases and obesity. And we have identified that there is a dietary pattern, which is a Western dietary pattern, which we call, what do we call it, Farah? Westernized dietary pattern that was linked to higher BMI. And this will be presented to you, the data on this study. So in conclusion, what do we conclude? Findings from our study shows that there is a high prevalence of adult obesity and high prevalence of non-communicable diseases. What are the risk factors associated with these obesity and non-communicable diseases? Older age, male sex, low education level, being married, low socioeconomic status, and possibly diet and physical activity. What is our recommendations? Is to address obesity and NCDs and make it of great significance for the country. Estimated yearly medical costs of obesity were 147 billions in the US in 2008. And it has been estimated that 1 unit increase in BMI will mean 1.9% increase in medical costs. So there are countries, even rich countries in the region, are worried. How are they going to treat their patients in the future? Because the numbers you have seen are 40% in some Gulf countries. So there is big campaigns to address obesity and non-communicable diseases. I have shown many conditions that are linked to obesity, but some of them are modifiable and they can be addressed, such as our diet. I mean, you can't ask people to divorce. You can ask them to change their diet. You can ask them to have more physical activity and make these two as the focus of attention. And of course, I cannot but emphasize the effect of smoking on cardiovascular diseases. I want to acknowledge before I conclude, and thank you for your attention, the group that has worked on this study. Dr. Abla Sibai was the co-principal investigator, and we have the Population Health and Nutrition Group, the research group, from the Faculty of Health Sciences and from the Department of Nutrition and Food Sciences. We have Farah Naja, Lara Nasruddin, Marie-Claire Chamiyi, and Nada Adra. And from the Faculty of Health Sciences, Lilian Ghandour, Monique Shaya, Rania Touma, Ziyad Mahfoud, and Blanche Ghandour. And thank you very much.